Hello, this is Kim Jong-il. We are going to cover the topic, elimination of occlusal force. Today's lecture is the second part on extraction treatment. Let's figure out how to utilize it. In the first lecture, I mentioned that occlusal force is needed to be eliminated when we cannot place the bracket in the accurate position in the non-extraction treatment. However, in Class 3 malocclusion, there is enough posterior vertical dimension. In this case, it's easy to place the bracket to the precise position. In Class 2 malocclusion, there is not enough posterior vertical dimension. When the bracket is placed in the lower, it's not easy to place the bracket to the accurate position. In other words, it is likely for the maxillary dentition to contact the bracket in the mandible. What problems would happen if the teeth contact the bracket? In this case, the best case is the dropout of the bracket. However, it's not dropped out easily due to the reinforcement of the bonding. 1. Increase in tooth mobility. 2. Severe crown lingual inclination of lower molars. 3. Aggravated mandibular curve of Wilson. 4. Restricted forward growth of mandible. In other words, it is likely for Class 2 malocclusion itself to become worse. Like this, we already knew how to attach the bracket to the accurate position by using blue resin composite resin to align the teeth. In the extraction treatment, we need to think over again. Which case do we perform extraction treatment more? Extraction treatment is performed in the high angle rather than low angle case. In high case, combination factor is usually small, and there are many cases for Class 2 malocclusion. In other words, there are many cases of Class 2 high-angle premolar extraction. What is the growth direction of Class 2 high-angle? The mandible is located backwards below. Especially the premolar extraction cases, we need to consider how to solve difficulty in accurate bracket placement and to lead to a favorable change of occlusal plane. In other words, we use blue resin when it's difficult to place the bracket in the accurate position, or removable devices such as anterior bite plate, posterior bite block, and twin block can be used. In the case of anterior bite plate, the lower incisors are put on the upper anterior bite plate. What about tooth movement? The lower molars extrude. The lower anterior teeth intrude. In this case, the occlusal plane itself rotates clockwise. In the case of posterior bite block, the lower molars intrude. On the other hand, the lower anterior teeth extrude. What about the occlusal plane? It rotates counterclockwise. There is another case, a twin block appliance. In the case of twin block appliance, the posterior vertical dimension increases in the posterior region. We can complete the occlusion by the tooth movement of both dentition using the increase in vertical dimension. In the case of premolar extraction, when eliminating the occlusal force, we need to check if it is normal overjet or large overjet. If it is a large overjet, it is likely to be Class 2 malocclusion. So, twin block appliance can be used and extraction treatment can be performed. On the other hand, if it is a normal overjet, posterior bite block is used in the case of high angle type, and it is likely for anterior bite plate to be used in the case of low angle deep bite. At this point, there are 3 purposes of elimination of occlusal force in extraction cases. 1. For the individual tooth movement. 2. For the molar forward movement. 3. For the malocclusion treatment. In the first case, the composite can be used to align the lateral incisors, located palatally, in proper position. In this case, there are many cases where there is a single tooth crowding or crossbite. Blue resin can be used for a short term, 1 or 2 months. In particular, in Mio treatment, not every appliance is attached in the beginning of the treatment due to strategic leveling. If we don't have to attach all the appliances, the blue resin is not necessary. As such, blue resin is required to align the teeth that are placed inside. Blue resin like this can be basically put on the upper first molar and the lower first molar. It is the principle to use blue resins for a month or 2. There is a case of a severe crowding on the upper right lateral incisor. I strategically leveled by extracting the upper first premolar and the lower second premolar. And then the tooth number 13 is located in place. Then tooth number 12 needs to be aligned. In order to align tooth number 12, the bracket was placed on the lingual side, and I leveled with 0.03 Hue Ni-T arch wire. Then there is a possibility that upper lateral incisors contact the lower teeth when the upper lateral incisors move forward. That's why we need to eliminate the occlusal force. The blue resin is put on the upper first molar, and the upper lateral incisors are moved labially to eliminate the occlusal force. Then the upper lateral incisors can be placed in position in 2 months. If the upper lateral incisors are placed in position, place the bracket in position. Place the bracket in position, remove the blue resin, and then keep on treatment. Even though it is severely lingually inclined, we can align the teeth in 1 or 2 months or 3 months. The second purpose to release the occlusal force is to move the posterior teeth forward. I used to use a convertible bracket in the mandibular first molar. If the appliance is attached in the beginning, there is no contact between the lower convertible bracket and upper tooth. However, it is likely for a convertible bracket to contact food like this due to the movement of the anterior dentition and food moving in. What would happen? It is likely for the lower first molar to be lingually inclined. If the lower molars inclined lingually, the lower molar couldn't move forward. So, in the case that the upper teeth contact lower teeth, especially the case of the lower second premolar extraction, it is more preferable to use a single buccal tube than a convertible bracket. In the case of the lower second premolar extraction, the lower first molar should be uprighted and moved forward. 2 upright, 0 degree of bracket is recommended. This prevents the overbite from getting deeper in anterior part. In other words, when the molar forward movement is needed, it is preferable to use a single buccal tube with 0 degree torque on the lower first molar rather than SWA convertible bracket. It's better to use a single buccal tube to eliminate the occlusal force. Also, Kim's bracket or 0 degree standard bracket is recommended to upright the lower molars. Generally, the crown lingual torque is applied in the SWA bracket. If the crown lingual torque is applied, the lower molar contacts cortical bone due to cortical bone anchorage, and forward movement of the lower molar is limited. Third, the occlusal force is eliminated for the malocclusion treatment. There is severe crowding on the tooth number 12. It's hard to place the bracket in the accurate position. Let's have a look at this patient. Deep bite is observed in the lower anterior teeth. It is hard to place the bracket in the accurate position. It shows a full class 2 canine relationship. The erupted the third molar in the upper and the impacted third molar in the lower is observed. This is a case of the upper first premolar extraction only. In order to eliminate the occlusal force, Schwartz PBBA is used in the mandible, i.e., it would be good to use a posterior bite block that covers the anterior teeth and rotate it once a week to solve the scissors bite. The upper canine is moved backwards. Then, it is possible to place the bracket in a somewhat accurate position. The upper canine is moved backwards, then the lower teeth are leveled strategically. Open coil spring is used on the tooth number 6, and the teeth mesially rotated can be uprighted and rotated parallelly. It becomes easier to place the appliance in the mandible. The extraction space in the maxilla can be closed by using combination loop and short class 2 elastics in the mandibular mio. As we close the space, the molars are mesially inclined and the anterior teeth move backwards. In order to compensate for such cases, if the elastics is applied from the upper loop to third and fourth loops in the lower mouth, the upper molars can be prevented from mesial inclination. Then use mio. While using mio, align the canine key, open the anterior bite, then use triangular elastics to coincide anterior occlusal relationship. This is the case that the treatment is over. If it is hard for the appliances to place in an accurate position, we need to think it over. We need to think of how to move the teeth efficiently by using appliances rather than just placing brackets. In other words, there is a case of Class 2 high-angle premolar extraction. Many extract premolar like this and then move the teeth backwards. What tooth movement would be made? By the posterior mandibular placement, and it is likely for the condyle itself to be located posteriorly by the posterior condylar movement. In this case, if we close the extraction space, moving the mandible forward first rather than extraction, the mandible moves forward, maxillo-mandibular incisors move backwards, and efficient tooth movement would be made. In particular, this is often observed in Class 2 premolar extraction cases. So we have to determine if it is full Class 2 or half Class 2. Then, the treatment should be performed after determining whether posterior bite block or twin block would be used. Even though there is deep overbite, in Class 2 high-angle case, if an anterior bite plate is used, how does the mandible move? The mandible rotates backwards below. In other words, if it is rotated clockwise, the mandible is placed downward backward instead of anterior mandibular movement. To compensate for this, in Class 2 high-angle case, it is recommended using posterior bite block rather than anterior bite plate. What would happen? The lower molars would be intruded, and the lower incisors would be extruded. Then the occlusal plane would be rotated counterclockwise. The mandible could be placed anteriorly. In the case of Class 2 premolar extraction, it is recommended to close the space by using the posterior bite block in the mandible. The lower molars would be intruded, the lower incisors would be extruded, then the occlusal plane would be rotated counterclockwise. By forming retrusive control on the resin in the lower first premolar and the upper second premolar, mandibular forward movement can be achieved. If the extraction space is closed, the upper canine moves backwards, it is easy to make Class 1 canine relationships. Also, the mandible is likely to be located anteriorly. We covered how to eliminate occlusal force. Resin buildup, anterior bite plate, Posterior bite block can be used and twin block as well. Especially in Class 2 premolar extraction cases, it is recommended to use the posterior bite block. Of course, in Class 2 non-extraction cases, twin block appliances would be used. So, if the posterior bite block is used, the lower molars would be intruded and the lower incisors would be extruded. Then the mandible would be placed anteriorly. Posterior bite block, twin block, etc. increase the vertical dimension like this. So it is recommended to use posterior bite block and twin block rather than anterior bite plate in Class 2 malocclusion, which has not enough posterior vertical dimension. Thank you for watching.